Good evening, everybody. I'm Professor Paul Lee. Today, I'm going to talk to you about the Asia syndrome. So this is one of our sport medicine lecture series from 108 Harley Street. I hope you enjoy my lectures. And we're going to talk about the link between the Gilmore's groin and osteitis pubis. So the Asia syndrome stands for adductor symphysis inguinal axis syndrome. So I'll talk a little bit more about it. So first of all, we want to talk about the area of the groin. So we can, as you can see, this is a diagram here, just to briefly talk about the anatomy. We're going to go into a little bit more detail later on, and I'm going to show you some more dissections and some graphic details of what the structure around the groin area between the Asia syndrome is about. So this is the common area that we're looking at between the lower part of the groin, which is the adductor, it attached to the pubic tubercle, and from superiorly, the inguinal ligaments is actually attached to the pubic tubercle. Now this have a big influence of athlete complaining of groin pain from time to time, and the Gilmore's groin is initially described. Of course, Mr. Marsh will be able to talk to you a lot more than me in terms of Gilmore's groin, as he has a lot more experience on the Gilmore's groin. What I'm going to talk about is that how the Gilmore's groin can affect the balance of the pelvis and actually cause osteitis pubis and the adductor tendon strain. So this is the anatomy, just a quick revision of, we got the inguinal ligament that attach here, and also we got the abdominal muscles that's here and the leg muscle that's from the bottom up. And hence, as an orthopedic surgeon, that's how I get involved from the leg muscle side. So with this, today we're going to talk about the anatomy, the pathophysiology, the pathology, how we usually treat them and how we should rehab them, and how the traditional rehab and traditional treatment has not been great and how have they failed. And also I would like to talk about how we treat them slightly differently in 108. So first of all, let's go to anatomy. If you want to talk about anatomy, we want to look at into the pubic symphysis. So this is a great paper if you got spare few hours. This is a really good paper with loads of diagram to review, but I have summarized it for you here. So this is one of the anatomy slides that from the paper, and on there is from the leg diagram that I showed you earlier on, and you can see that in the bottom here, the AL is adductor longus, so it's attaching. So it's this muscle going all the way up here, attaching to the pubic tubercle, and then the inguinal ligament is on the top of the tubercle and go across here. At the superior margin of the pelvis here, on the pubic symphysis here, that's the rectus abdominosus, which is represent this muscle. And then this muscle here is the other side, the opposite side. This one is the adductor magnus muscle down here. And then if we're looking at the cross section of the pubic symphysis, we can see that this is where the bone is. And between the two bones, there is this structure here, which is a cartilaginous type structure, very similar actually to the spinal discs. And so it's filled with type 1 and type 2 collagen within the within this structure here, symphysis discs, and that is basically, it's not supposed to have any movement. There is a ligament in the front and there's ligament in the back, and that is basically holding the two sides of the pelvic bone together. So that's what it looked like in the cross section. Now, again, this picture might show a little bit more of the cross section, with other anatomy coming into play as well. And as you can see in the middle here, that's where the pubic symphysis is, and the middle here, that's where we're looking at the symphysis discs. And then the ligaments I'll talk about in the front, and ligaments I'll talk about at the back. You can see there's quite a lot of structure nearby, a lot of muscle nearby. And one of the questions that is quite difficult. Sometimes it's quite difficult to diagnose, because patients often, they don't know who they really go to, in terms of their groin pain, because sometimes they see a general surgeon, is it a hernia, or they go to see an orthopedic surgeon that people usually think about, oh, is it a hip problem or is it a calm lesion? But actually, what if we take a more detailed history, they actually having a problem in the middle of the pubic symphysis, or maybe actually at the attachment of the adductors, and that's very common, especially on the sporty person. And I'll explain why. And that's something that I think is from it passed on from earlier on in the textbook, and even got some old slide that Mr. Marsh have kindly lent to me to present from Mr. Gilmore before as well. So let's look at the bony anatomy first, as an orthopedic surgeon. So first of all, of course, we want to look at bones. And it is not that interesting in terms of the bone. It is just like a structure here. That's a hard structure, but it's like a disc-shaped structure here. And it is very similar. Later on, you will hear something from my colleague, upper limb colleague, Mr. Hewlett, and he probably would tell you that it look a little bit like the glenoid in the shoulder, but it's just a very, very small part of it is a concave structure for the one side of the pubic symphysis. And then because the middle is the cartilaginous structure that I was talking about, the disc structure talking about, and that is the schematic diagram that show that it look a little bit like the spinal discs. There's connective tissue, there is collagen within there, and there is a bit of a nucleus inside as well. This is a histology to show the difference in the difference of a virgin to someone that have babies, and you can see the difference between the pubic symphysis is slightly more open up with patients that have babies been delivered, and as the pelvis having slightly wider. It's not often a problem, and what we're looking at here is very small, but usually the ligaments in the front, in the anterior and the posterior aspect around the pelvis is strong enough to hold the pelvis together, and it doesn't usually cause too much problem. However, we do sometimes see patients that is postpartum and have issues about walking, and they got this deep groin pain, and something that we can look into. And this is what it looked like in the MRI scan, and we want to look at it very carefully, and with the very experienced consultant working with us in 108, we radiologists that we have very, very fortunate that we were able to pick up osteitis pubis, disc disruption, and actually sometimes we even get the report down to the minute detail of the anterior ligament that gets information. But again, it is very important when we're looking at an MRI scan is if you don't know what you're looking at, a lot of the time this type of thing can be missed. What we're looking at here is that so this is the pelvic, the pelvic bone here in the middle. That's where the disc is, and then this is where the muscle attachment into the bone as well. So that's a bit that we usually look at, and of course at the top here, that's where the internal and external oblique, not on this cut, of course. And then we can sometimes see the muscle disruption there for Gilmore's groins. Now, when we're talking about Gilmore's groin, of course, we have to mention the great Jerry Gilmore, and that's he's the first one to describe about the Gilmore's groin and how do we treat Gilmore's groin. And this is the slide that I get from borrowed from Mr. Marsh, and he took it initially from Mr. Gilmore. Basically, he talked about the Gilmore groins, about the etiology. The etiology of the Gilmore groins is he think that the flexor is too strong. Therefore, the pelvis is tilted and stretched the abdominal muscles, the obliques muscle, and therefore it caused a tear in there. And then on the next photo, it will be a bit easier to understand, as it is a diagram that is again from Mr. Gilmore's slides. And so on here, you can see that if he's talking about a very strong, number one, strong quadricep muscle pulling the pelvis downward. Therefore, we're stretching this oblique muscle and causing the tear within the muscle. Now, this is the observation from Mr. Gilmore back here, 30, 40 years back, and I think this is a great connection from the Gilmore's groin to the osteitis pubis, as well as adductor tendinosis and adductor tendinopathy. And this is why we come up with this Asia syndrome. So first of all, so I just want to explain to this in a slightly simpler fashion. So as I showed you earlier on the anatomy, you can see this is where the pelvis is. In the middle, there's our symphysis discs in here. And then you can see that on the diagram that I showed you before and on the anatomy that I showed you before, this is the rectus abdominosus attaching to here. Now, these muscles, when they contract, they create a upward force that will pull these bones up, the pelvis up. Now, of course, we must not forget there is a inguinal ligament going down there attached to the tubercle. And then the obliques are attached to the inguinal ligament. And then when the obliques contract, they will actually create a slightly diagonal force. So the overall vector or overall force generated by these two muscles is pulling the pelvis inwards. Of course, and we talked, as we all know, that Isaac Newton have told us that every force on one way have to have a reaction force, and the reaction force, as you probably can figure it out by now, is the adductus muscle at the back, which is attached to the bottom of the pubic tubercle, and it will create the force that contract and pull the pelvis, pull it back down. And of course, don't forget about the strong quadricep muscle that will create the downward force. So in total, it will create the force on the opposite direction. Otherwise, our pelvis will keep on moving forever. So this is just a quick reminder about the so physics actually come into it as well. It's great, isn't it? So yeah, this is just a quick summary. So this is how the forces are acting on our pelvis. Now the interesting thing is these forces need to be balanced, and from the top and the bottom. Otherwise, things will move, as Newton told us. The interesting thing is, if there is a slight imbalance, for example, for sportsmen, they train very hard on their quads, build their hamstring really strong at the bottom part, and then the upper body, the core is not as strong. Therefore, the force at the bottom, as Mr. Gilmore told us, that is much stronger on the quadricep, and therefore the force on the obliques is a lot less. Therefore, what happened is it will stretch those obliques out and pull that over. Now, when the muscle is stretched, it's no longer as strong, so therefore it came into a vicious cycle. When that happened, the pubic symphysis will start moving, because instead of the muscle taking away the force, the ligament will start have to do the work instead of the muscle. By doing that, if there is a disruption in the symphysis, the pelvis start moving, it will cause inflammation. What I'm showing you here is just one plane of forces. Now, of course, we have three-dimensional structure. We haven't even talking about the lateral force and also the posterior force and also any rotational force. Don't worry, I'm not going to go down that route because it's very complicated. But as you can see, that one of the things that is really important just to understand is that the obliques muscle is actually taking a lot of load to the body, because the internal external oblique muscle doesn't just attach to the front to the inguinal ligament, it attaches all the way back to the back of the pelvis as well, to our rib cage. So actually these muscles are doing a lot of work in compensating and playing opposite reaction force to our quadricep and our very big hamstring sometimes. So all these take into play, and if there's any muscle imbalance, it usually creates a twisting force and a rotational direction force within the pubic symphysis, and that's actually what causes the problem, the degeneration, the issues, the bone swelling, and all the problem that happen within the osteitis pubis. So one of the issue is that is it sometimes is osteitis pubis caused by muscle imbalance, or is it because the muscle imbalance causes the osteitis pubis? It's very difficult to say. I think it really depends. If somebody is normal, I would say 9 out of 10 times is usually caused by an injury. If you talk to the patient, they would, if you go back enough, and when they remember how they first got it, usually it lead to something. Most of the time, well, it's a sport injury clinic that we see people that have issue, and they usually bring it down to some sort of special training regime that they have done in that 1 year, and then since then it had problem with niggling on and didn't settle down and getting worse and worse and worse. In the literature, you can see, we can actually talk about there is different grade that people have decided about how to grade osteoitis pubis. That's grade 1 to grade 4, but I've read through that paper a few times, but then that paper is based on a case study. They're talking about basically, is it a unilateral, is it bilateral, has the adductor get involved, and things like that. I'm not sure is it the best way to grade it, but it is. If you read the literature, you can grade it differently. I think it's more important is that we want to look at it and think of it based on MRI scan, and based on when we try to work out which muscle is weak, and actually is that a problem within the symphysis disc itself. So based on what I was telling you on the just now, it is, so we have defined this syndrome called Asia syndrome because it is something that is not just it is cross specialty. It is something that will have to be, work together between general surgeons as well as orthopedic surgeons, because we look at things slightly differently. And the treatment, sometimes Mr. Marsh has repaired someone's on their Gilmore's groin very successfully, and then actually later on they come up with a issue with the adductors because the muscle is not balanced, and actually we need to get that rebalance, and that's. And it's really important that we want to stress the fact that this is actually really connected, and then we see quite a lot of this problem here. When we're looking at the treatment options, as I say about in the aim of the treatment, this is one of the treatment regimes that we can find in some published literature. There is a systematic review of osteoitis pubis and how to treat them, and how physio can, what physio regime they have done, and this is basically they have summarized it into these 4 stages, different way to do it. But at the end, when you finish reading through this rehabilitation stages and how you should do it, very interestingly, they have just saying that the result is poor. So basically, they tell you what not to do, which is fine. But then I think the issue here, if you look at here, they were talking about they want people to do stretching, and they want people to go on the bike. And if you really think about it, but as I show you about the anatomy, I show you about how the muscle are working, it might not be a good idea to actually go on a bike, because in a very early stage, because you're creating this shear up and down forces on your quads that really pull on this and creating this shear force on the pubic symphysis, as well as stretching. As Mr. Gilmore told us, that the stretch, it was the muscle overstretch is the problem. So we don't really want to stretch that overstretched muscle. So that's my own opinion why these things have these people would have a potentially this rehab regime have not a very good result. So just remind you about the slides that I showed you earlier on about the course of the Gilmore's groin on the and the sportsman hernia is basically this part here, the obliques getting stretched. So if you want to treat this, how would you want to do it if you want to sit back and think about it? I think if we need to treat it on the opposite side. If we're going to stretch, we don't want to stretch this side. We don't want to stretch the side got pain. We want to stretch the other side to try to balance it out. And want to, in a way, deconditioning this strong quad on one side and train on the other side. Perhaps that may be the way forward. Now, I think the key is we shouldn't stretch too early as well. So in terms of treatment option, this is how we do it in N08 and how we're thinking about how to treat the patient. Is something that I do quite a lot is using the platelet-rich plasma to treat osteoitis pubis and tendinosis. We know that tendinosis and or somebody call it tendinitis is not really an inflammatory condition. It's more a degenerative condition instead of a inflammatory condition. Most of the tendon and ligament condition nowadays, as science progresses, we understand that it is more of a degeneration than an inflammation. So therefore, in my books, I do not think there's any role of steroid in treating this type of condition. And also, you don't have to take my word for it. If you look at a systematic review, or you can just search osteoitis pubis and steroid, all the paper come up in there, they have poor result. They have good result for the first 3 months, and then after that, they all relapse very quickly. The reason is that steroid is not a biological drug, biological substance. It is a drug, and it just numbs the pain. And the theory of anti-inflammatory doesn't really work. I'm sure you heard this many times, so I'm not going to dwell too much on it. So therefore, I tend to use PRP instead of steroid because I want to reintroduce the biology into the body. Now, you might hear some people say that for PRP injection, you need 3 injections, you need 5 injections. I don't buy that either, because I think we should actually use the injection and think about how the biology work instead of just monetary, give somebody 3 injections and somebody 5 injections. So this is my regime as such. That's how we treat them. So what I tend to do is I use 1 dose of PRP, inject into the area of, for example, osteitis pubis. We inject into the symphysis disc. By what we aiming to do is to introduce the growth factors into the symphysis and allow the body to heal. I ask them to have absolutely complete rest for 3 weeks. If they don't rest, it's no point having the injection. And if they want to return to sport early, I tell them don't bother. Wait until you have your off season, wait until your season finished. But during this time, just take some painkiller and wait. So because we need the biology to work. If the biology doesn't work, it's no point. I asked them to rest for 3 weeks. The reason is that there is a collagen turnover in the body. It takes approximately 3 weeks, and this is why we go it that way. And then during that time, I asked them to do upper body exercise, but not very rigorous exercise, because sometimes when you do upper body exercise, the core have to stabilize the body, and actually that's causing more stress. As much rest as possible. I sometimes tell them absolutely complete rest. Well, like lockdown, I suppose, or maybe 1% to what they used to do, and they will have to follow that regime. And then after that 3 weeks, they can start stretching, but they stretch the opposite side. If it's only, if it's unilateral. If it's bilateral, no stretching at all, just leave it. And then we will start slow, and we will start from swimming if it's possible, and then we don't introduce cycling until 6 weeks time. The reason of 6 weeks, beside it is an orthopedic unit, is that I want 2 cycles of collagen turnover before we want to really think about stressing that again. And running, I think, is all guided by symptoms. If the symptoms allow, then everything is going well, then we can return to running in 3 months' time. In terms of the injection, as I alluded on earlier, on how many injections shall we give? We usually give 1 injection. Patient either get better, or there's 3 things can happen. They either get better, or they get a little bit better but not completely healed, or they have done nothing at all. If they are better, there's no point having a second injection. If they are not better, it doesn't work at all, there's no point doing it again. If they get 50% better or slightly better, then I think that would be a good argument to do another injection. And I think this is how we should work it down as a biology instead of a monetary figure. So here is my result so far for the last couple of years. The results generally are good. Most people require just 1 injection. Some people require 2. And yes, of course, sometimes where it happens, it didn't work at all. But other than that, this is my presentation of Asia syndrome, osteitis pubis. But what I want to say is that it is a treatment and is a condition that is something that we need to have combined from the general surgeon as well as orthopedic surgeon in order to treat this condition.